So as everybody logs on, again, welcome back. Really cool topic tonight. I found a great article coming out from Human Reproduction, not even released yet, about how long it actually takes you to conceive if you have fertility issues, but you are actually trying to conceive after the age of 35. And you're not actually using therapy. So just natural conception after the age of 35. How is it? How long does it take? What's the probability? And so on. So it's a really cool article. And lots of really great data going on there. So that should be a good topic. And hopefully you guys can all hear us. I know you can on Instagram. I'm assuming you guys can hear us on the YouTube and Facebook and Twitter feeds as well. Tark checked it out, so everybody should be good. Hi to everybody, welcome back. So now that all the glitches I think are over, we're going to get right into it. So I'm going to start by saying I apologize. I had a very long surgery today, which probably aged me a couple of years. So I'm a little bit more scruffy than normal. I usually like to shave for you guys. So this is the scruffy version of Dr. Victory. My apologies to all of you for not being as well kempt as I should be. Okay, so the topic is a really cool article. It's called Age-Related Natural Fertility Outcomes in Women Over 35 Years, a Systematic Review and Individual Participant Data Meta-Analysis. So the question which these guys asked, which I think should be huge for everybody out there really wanting to know, is if you have infertility, but you don't do treatment, what's the chance that you're actually going to get pregnant? Is it 5%? Is it 10%? Is it 20%? How long will it take? Does it depend on any factors and so on? So these guys actually looked at that. They went back and they reviewed studies that examine natural fertility and said, how can we pile all this data in together so we can get some good answers on what happens? And this is a really interesting topic for me because, as you know, I'm a big supporter of trying to keep your costs down, not doing stuff that's ridiculously expensive necessarily, and not pushing everybody into IVF. A lot of fertility centers are wholly dependent on their IVF model. And so if you're not doing IVF, they're not making money. Obviously, if they're not making money, they can't stay open and they can't pay for their expensive houses and cars and all that other stuff. We're really not like that. I don't need to have a bigger house and I love my car, so I'm all good. And so we really want to push you for nothing. I don't push people into anything. We want you to do what's right for you. So we always give you options. And I always sit down with my patients and I say, here are your whole range of options after we've discussed what's wrong. And you could do this, you could do that, you could do the other thing. Here are the chances, here are the success rates, and what would you like us to do for you? So we very much try and put control back in your hands. We have an amazing person that works with us who specializes in trauma and mental trauma. And she kind of coached us through some of these things. And one of the things she told me is fertility is a huge loss of control for our patients. And she wanted us to make sure that our patients understood that we sympathize with that loss of control. And we want you to understand that we want to return and restore the control back to you. So rather than us saying you should do this or you should do that, it's really very much about us saying you should do whatever's best for you. Tell us what that is after we've taught you what's wrong and what your choices are and what they all mean for you. So this study's great because this actually rolls it all the way back to basics and says, what if we do absolutely nothing? What if we just leave you alone and we don't touch you and you're at home and you're trying on your own? So the way that they did the study was they went around looking for other studies that had analyzed this. So this is not a single study looking at what had happened over time. This is a longer study looking at or not longer, but a different type of study looking at bringing in other studies that had looked at that question and piling the data together to get an answer. And that's called a meta-analysis. So they found 9 studies that qualified based on their characteristics. So 2 were actually randomized controlled trials, that's that higher level data, and 7 were cohort studies where they kind of started with a population and they followed them through time to see what would happen. And they needed data for women that were at least 35 years old. So this does not apply to the women that are younger. If you're in that younger age category, I don't have a whole lot of information for you here. This is catered a little bit more towards the women that are a bit older, although it should give hope to everybody based on what I'll go through with you. And they basically analyze the quality of the studies too. This is an important part of doing meta-analysis. They'll tell you if there's high quality or low quality studies. They'll tell you how much it's called heterogeneity, which is the mix of how it was conducted and how it was run between the two. And so based on that, they'll come up with kind of an assessment to say it's a good study, it's a poor study, it's got low heterogeneity, it's got high heterogeneity. So lots of really interesting ways to mark and to grade kind of the data that's going in it. Because obviously, this is like, baking a cake. If you put in crappy ingredients, you're not going to get a good cake. Same thing with this. If you put in bad studies, you're not going to get a good answer out of it. You need to put in good quality studies. So they were actually pleased because most of the studies were of moderate to high quality. So they then went ahead, compiled the data, and they pulled out this really interesting graph and some really interesting results. So I will go through that. And let me, for our viewers on our other platforms aside from Instagram, sorry, my Instagram friends, we are going to show you application window, which doesn't have it. Tarek, it's gone, my friend. It's there, but it's not on this one.
Just click on.
1 second, folks, while we get it. Click on this one?
Yeah.
But that's the one we're on.
Yeah.
Click it?
Yeah.
I don't think so. That's the one we're on. That's putting us back up again.
And then share it from here. Is it sharing?
I have no idea. You want to check online and we'll see? So Tarek's just checking to make sure. So I'm going to scroll through this and get to the graph that I want to show you. And if we can't, I'll just hold it up for you guys to see. It's pretty small, so you'll get the view that you want. Okay. We're almost there. Okay, this is the graph here. So let's see if we can kind of hone in on that one a little bit. Right there. Can you see it?
No, I don't see it.
Oh, okay. Let's stop sharing. So give us 1 sec, folks. We're just going to try and get the system to work a bit better for us. Screen share again. No, it's not what happened. It was. We had it all set up earlier. Ah, there we go. Okay. Okay, perfect. So the graph, folks, on Instagram looks a lot like, and in fact, exactly like this here. So I'm going to hold it up so you can see it there. So it's this one right here. You've got an upper line and a whole bunch of these lower lines. And on this axis, it's your probability. And on that axis, it's your time. So when they followed these women, they broke them up into different categories. So for those of you who are watching on the sharing system, you should be able to see that the colored lines at the bottom are the different types of infertility that are categorized. And the dark line at the top, and for the folks on Instagram, it's this one right here. This one is unexplained infertility. So this is very, very interesting data. The reason is the numbers are important. So 4 couples, beginning with, this is just kind of everybody over the age of 35 who had unexplained infertility. If you waited up to a year, about 20% of the patients became pregnant. For the other categories, it was only between 5 to 10% pregnancy, with variations based on which category you were in. So the pink dotted line is tubal factor. More of those were able to get pregnant. The darker blue line is male factor. Less of those were able to get pregnant naturally. So depending on your fertility diagnosis, there were subtle variations, but a big difference with unexplained versus explained or diagnosed conditions. Why is this interesting? This is interesting because traditionally, the patients with unexplained infertility actually don't do as well. So normally when we're quoting stats, we tell you that the rates of success with unexplained infertility are a lot lower. And this study is actually saying it's much higher when you're only trying naturally. So there may be a difference for the unexplained group between trying naturally and trying with therapy such as insemination or IVF or surgery. The other graph that's quite interesting is the effect of female age on the probability. So when you looked at, and these were all for live birth, by the way. So when you looked at the age one, which is this one here, so again, this is your probability and this is your age, and you can see that the line very quickly falls off. So up here, you're dealing with a number of around 23% probability at age 35. And by the time you're getting out to 43, it's about 12%. Again, that's kind of an important number because that's telling you at 43, where a lot of people are absolutely terrified and they're worried, if you waited long enough, within 12 months, you still had a 12% chance of getting pregnant and going on to have a live birth. So this wasn't just having a pregnancy and then having a miscarriage. These are people that actually did quite well, made it all the way through, had a normal pregnancy and delivered. The last graph that's there, here we go, whoops, sorry, is this final one down at the bottom. And this is for unexplained infertility, so you guys can all see that. And that unexplained infertility graph is showing, it's called the Kaplan-Meier curve. So that's the cumulative probability that you would go on to have an ongoing pregnancy. So it's not live birth, it's ongoing pregnancy. So at 6 months or half a year, you were looking roughly in the 12-13% range for patients with unexplained. By the time they got out to a year, it was around 22% or so. And by the time you got out to a year and a half, it was even higher. You're looking at about a 27-28% range. So for some people, if they don't want to do anything at all, we don't need to force you to do therapy. You can actually wait, and you have a reasonable chance of success. They further broke this down. Let me just stop sharing for a moment while I get this all set up for you guys. So I want to show you this one again on another graph here. And let's go there. Yeah. So when you look at this one, what it shows you is at the age of 35, and this is kind of hard to show the folks on Instagram, but I highlighted it. And I can show you where to find this study, but you can see all these highlights, okay? So I'm going to read the numbers to you for the Instagram crew so you'll know what's going on. So if you had primary infertility, so you've never been pregnant before, you are 35 years of age and you've been infertile for 1 year, so you've been trying for a year to conceive, your chance within 12 months of getting pregnant was actually 29%. So that's a really good, chance of conceiving. When you got down to the point where you had tried for 2 years, that number drops quite a bit and goes down to 24%, so a 5% decrease. With the increase in duration of infertility, when you get down to 3 years, now it's down drastically to 14%, and so on and so forth. By comparison, if you're age, let's say 40, and you're trying, your initial chance after 12 months is 22%. By the time, and that's again that unexplained group, right? By the time you get down to 2 years, and that's for 1 year of infertility, by the time you get to 2 years of infertility, you're talking about an 18% chance, so a little bit of a drop, but not as bad in that age group. By the time you get down to 3 years of infertility and you're 40 years of age, it's down to just 10%. Interestingly, when they looked at this for secondary infertilities, meaning you've had a baby before, now you're trying again, they had more robust success rates, but a similar pattern. So you're 35, you're trying for 1 year, you have secondary infertility, so you've been pregnant before, but now you're trying for a year, it's not happening. Your chance after 12 months is actually 35% overall after trying for 12 months of conceiving and having a baby. So that's pretty good. If you are 40, it's 26%, so still pretty good. That's for 1 year data. If you're trying with 2 year data, it's 29% after a year of trying. And if you're 40, it's 22%. So the numbers are more robust than they were when you have primary infertility and you've never been pregnant before, but they're obviously not as good as ideally we'd like them to be. And you still are seeing that pattern where age plays a very significant role. So does everybody need to have fertility treatment when they are trying to get pregnant? The answer to that is no, not everybody needs to have fertility treatment. You have very robust, reasonable success rates with any kind of therapy, including none. And so you should never feel forced into treatment. So remember, we just posted recently about the fact that patients who want to wait even up to 6 months, even when their AMH is low or their age is higher, have no difference in their outcomes as far as live birth. And now you've got additional data that shows that you actually have a very reasonable success rate, even if you're trying just 6 months or a year. So number one, don't feel panicked. Even if you're older and you're experiencing infertility, there are lots of options. There are lots of choices for you. Number two, never feel pressured. No one should be pressuring you into therapy of any kind. A lot of places do kind of high pressure sales tactics. They want you in IVF. They want you throwing in the PGT. They want you doing the ERA. They want you doing this, that, and the other thing. And it may not even be necessary. You might be okay being told, like, go home and have a good time, like, relax. And I don't mean it in the relax part of it in terms of people hate it when they're told to go relax and it'll just happen. But I mean, you shouldn't feel stressed or strained by your fertility center telling you you need to jump into therapy right away, because you probably don't. You got very realistic outcomes, even if we do absolutely nothing to you and you choose for yourself to just go try some vitamins or try some acupuncture or just try having more sex or less sex or whatever works for you, but just delaying and starting later. So yes, we offer all sorts of great opportunities for you. Yes, there are many people we need to help. And keep in mind, the real robust data from this study is for unexplained infertility patients. So for the ones who have a diagnosis, the chances were much, much lower. And you got to factor that in. If you're tubal or endo or male factor or any of those things, you might be playing with a different ball game. And in that sense, you need to be really cautious and make sure that you know what you're doing. But overall, it is a fiction that you need to do treatment right away. You have the time and the luxury and the right to take your time, make a rational decision that's good for you. Do not feel pressured by any fertility center or specialist to jump into treatment. You got opportunities to just do things without having to spend a fortune, and hopefully without all the strain and the stress that often comes along with fertility treatments. So I love this topic. I hope you guys did too. Make sure you like, subscribe, comment on our YouTube channel. Make sure you go to our YouTube channel. All our videos are there. We've also started posting little ones in answer to questions that we find on the web all the time. So there's lots of stuff there now about why IUI doesn't succeed, why people only make a certain number of eggs. So great information for you guys or any of your friends that are looking for info. So with that, I'm done the fact or fiction component. We'll start taking the questions. Hopefully you guys all like this episode, and make sure you share it with anyone that's interested in this topic. So do you want me to start here or you want to start there?
Start there.
You want me to start here? All right. Great topic. It is a good topic. Okay, can you explain mini IVF? Is it suitable for someone who is high risk for medical procedures due to cancer treatment? Oh, that's a great question. Okay, so mini IVF is the process where we use a low dose of gonadotropins. Those are the injectable medications that we use to stimulate your ovaries. And we are aiming really for about 2 or 3 eggs. To me, it's actually never made any sense whatsoever for anybody. And the reason for that is 2 or 3 eggs really is not beneficial for anyone unless you have a religious objection to producing lots of embryos, in which case that's okay. Make lots of eggs and freeze your eggs, because the cost is really not drastically different between the mini and a normal IVF cycle. And because of that, you're really not getting any value. And you may object to having frozen embryos, and I'm totally respectful of that, but no one objects to frozen eggs because it's just an egg. It's not a life form yet. So even in very religiously strict countries, Spain, for example, you're allowed to freeze as many eggs as you want. You just can't freeze a lot of embryos. I don't think they allow more than 3 at a time. So mini IVF, I'm not a huge fan of. I have done it before on the odd occasion, but essentially it's designed to help you make only a few eggs. Now, is it beneficial for someone with cancer treatment? If you've had breast cancer, there are IVF protocols that involve letrozole that minimize your chances. So I'm actually treating a cancer patient right now who we're doing IVF on to get egg retrieval before she goes through her chemo. So we use these protocols that actually keep your estrogen levels quite low, and you can do very well, and the outcomes show that it's very good and there's no harm or damage done. So you don't really need a mini IVF cycle even if you previously had breast cancer. If you are talking about other types of cancer and you've had chemo already, there's a fairly substantial likelihood that your ovaries are not going to respond well. And that's because they may have suffered damage from the chemo, which is very, very common. And if your ovaries have suffered damage, they're not going to work really well. So mini IVF may be fine in terms of saving you money on your drug costs, but it actually probably won't make a big difference in terms of outcomes. One thing I do kind of like, and we favor probably a little bit more than mini IVF, is just natural IVF. So with natural IVF, you need very, very little medications, usually just 2 or 3 days of a super low dose, if even that. And it works great, and it is substantially cheaper, almost half the cost of a full IVF cycle, between 2/3 and a half. So that's a real reasonable approach, especially if you're worried about cancer treatment. So great question. Thank you for asking that. Lots of likes for that lovely person that asked. Is there a safe way to boost chances of pregnancy after having issues conceiving before? So this is like the most common question we get asked. What can I do to improve my chances? So healthy diet, number one. So Mediterranean diet's favorable, low carbs, low sugar, low inflammation. Number two, you want to have lots of vitamins, especially your vitamin D level. You want your vitamin D level to be high, and so that will really help you as well. Exercise, including bringing your weight down to a reasonable level. That's really critical if your BMI is an important factor for you. Make sure that there are no substances that are interfering. So smoking, drinking, drug use, you got to get rid of all of those, or at least absolutely minimize drinking to the least amount possible if you can't stop. But drug use and smoking are just absolute no's. And then aside from that, try every 2 to 3 days, lots of antioxidants. So green tea, healthy vegetables, lots of foods that are rich in antioxidant capacity. More of a vegetarian diet is probably beneficial as well. So those are all the things that can help you conceive naturally. A naturopath may be able to help you. Acupuncture, cupping, our amazing Dr. Jennifer Strong. She's just making a video here tonight that should be up and running soon. What was that on? Acupuncture? Yeah? Okay, so we'll have an acupuncture video on our site soon. We're actually creating Jen her own little tab on our website, so we're going to have a whole naturopathic aspect to our treatments here, which we've had the whole time, but we're going to add her onto the website so you guys can check it out. Can you continue to breastfeed while doing an FET? No, you cannot breastfeed while doing an FET. The high prolactin levels will interfere with the development of your endometrium, and the endometrium will not be favorable towards implantation. So that is a no. Yeah.
Can you explain HLA-KIR?
I saw that earlier.
You're much easier to understand than
yeah. So I'm not quite familiar with HLA-KIR. I'm not sure if you actually meant natural killer cells. So natural killer cells are a specific subtype of macrophage and white blood cell that actually goes in and kills things. And so it can attack an embryo, especially if you have the bad kind. So there are ways to quell that, and people have studied that, and whether or not it works is controversial. My amazing friend and colleague Fred Zizneku and his wife Chloe Romain are two fertility endocrinologists and as well immunologists, and they do a lot of that work. So we refer a lot of our patients to them, but we've actually started doing the treatments here at our Windsor site. Amazing stuff. We've already started one of our patients on IG therapy, subcutaneous instead of IV, and it's being done for free, which is amazing. So thank you very much to Fred and Chloe who got that set up for us. So yeah, I mean, there are things we can do for that. If it's something else for HLA-KIR, I'm not familiar with that. I'll have to look it up, but maybe I'll post what that is. Why don't you remind me and I'll post HLA-KIR. What's next?
Is DHEA good for women with DOR who will be doing IVF treatments?
Yeah, so that I saw that question too. So the question is DHEA, the hormone, helpful for IVF? So the answer is, to date, the most studies that there are show that you can increase the number of eggs that you will normally produce by taking DHEA. And in my experience, it's only about 1 or 2, and that's what most of the studies show. But it does not increase the live birth rate. So is it useful to take something that's going to increase the number of eggs but not the live birth rate? Maybe. Why am I saying that? Well, in theory, if you're making more eggs, maybe it just clicks in that one time you find the right one. And maybe we don't have a good enough or a big enough study to demonstrate that it would improve the live birth rate. So are more eggs a bad thing? Almost never. And so there's really no downside to taking the DHEA. Certainly no study has ever shown that it is detrimental. So I'm in favor of trying, but you need to be sure that you are taking it for all the right reasons. And it does have side effects. We get a lot of women that call me and say, oh, I'm breaking out, or I'm getting a beard, and so on. You won't get a beard, but you will get some acne breakouts. So yes, I would recommend trying it. We use it all the time.
How do embryos make sure to label eggs and sperm and transfer correct embryo?
How do we make sure we label the embryos? Embryos are tagged in the straw that they go into, and it is triple and quadruple checked, and we're actually bringing in a radio frequency identification system to make sure that it's impossible to put anybody's embryo into anyone but them. But we literally triple check before the embryo goes in you, so it's never happened before. So we're very, very cautious about that.
Same questionnaire. How many days of progesterone before transfer is the best?
So we just discussed this, yeah. So we just discussed this on, was it 2 weeks ago we did that one, or was that last week?
That's last week. I feel that was last week. 6 or 7 days.
Was that last week? I can't remember. It was last week or the week before, but so we just answered that. So it appears that there can be differences of what's appropriate. And so it kind of depends on you and the duration that it took for your embryo to get to the stage that it's supposed to. Normally, people will do 5 days of progesterone, and then you transfer after completion of 5 days. So that's on the morning of the 6th day. But in many cases, it's actually day 6 or even 7 that can be appropriate, because of the duration that it took the embryo to get to the correct stage. You want me to take one from here?
Yeah, take something there.
Any news with rebooking canceled surgeries? Yes. No one was canceled. It was just delayed. And the information is not good. Right now, it is looking like at least until October, they are planning on maintaining our current status, which is, for me, instead of 4 to 5 days of surgery per month, 1 day every 6 weeks. So it is going to take an awful long time. Here's a good one. Is skim milk, low-fat dairy bad when you're trying to conceive? And the answer to that is, some people believe so, and probably if you ask the naturopaths, and I certainly don't want to speak on behalf of Jen, but I suspect she'll say this, it's better to avoid dairy. Dairy does have non-human antibodies in it, and some people's gut can react to that. And if you throw your gut out of balance, you can actually alter everything inside you. So keeping the bacterial content of your gut kind of stabilized is actually really important to how your whole body works. And so this is very important. So do you have to avoid it? No, I wouldn't suddenly go dairy-free. But is it better to minimize it? I don't believe there are any studies, but it probably does make sense to have less dairy. Very informative. Thanks. You're welcome. Is it considered primary or secondary infertility if you've had a baby through IVF before? Great question. So anytime you've previously been pregnant, you no longer have primary infertility. So secondary is when you've previously been pregnant. Primary is when you've never been pregnant before. Let me do one more quick one. Does crinone delay your period? Yes. If you're on crinone, it will definitely delay your period in many, many cases because you actually have your period because of the withdrawal of progesterone from your bloodstream and your uterus, of course. And if you are on crinone, you're actually supporting that progesterone level, so there is no withdrawal. So none of the changes that need to occur in order for you to have your period. So in many instances, you won't get there. Let me read one more quick one. I love how I don't push things, how you don't push things, me being the you. I love to come see you. I had a referral to you from my family doctor shortly before COVID hit. Can I just call you directly, or do I have to get another referral from my family doctor? I don't think he actually sent the first one. So yeah, just have your family doctor send the referral. No, you can't call me directly, just because it would be unfair to everybody else. And my office manager would actually kill me. But make sure that you just have the referral sent to our office and we can do it from there. Yeah.
What progesterone and oil do you recommend? Which one uses the smallest needle?
All the oils are pretty much the same, although some women react differently to them. So actually you need to test it. So there isn't one that's particularly better than the others. So try it out and see which one works best for you. There are some women that get these very horrible, firm, pink or red, even welts from the progesterone injections. If you are getting that, you're reacting to it. And I strongly believe that those people's immune systems get activated and that their chances drastically drop. So if you're getting that, not only should you not transfer, stop, change your progesterone, start the whole thing over and go again.
What is the optimal range of lining thickness 1 week before FET?
So lining thickness, generally speaking, most people will say you want it around 8 millimeters. So if you're a little bit less, it might be okay. And if you're a little bit higher, up as high as 1.2, it's okay. But if you're getting up into the 1.4, 1.6s, your chances will drop, and there is evidence for that. So ideally, that magic number is get it to 0.8, and then you're in good shape. And remember, because a lot of people don't know this, after you start progesterone, it should shrink. If your lining does not shrink after you started progesterone, you either don't have enough progesterone or it's not going to be good. And there is a study that shows your chances will drop dramatically.
Research proven post-transfer do's and don'ts to increase success of implantation.
Do anything normal. Have sex. That we reviewed that in a fertility factor fiction, so you can go back and look at that one too. That was a couple of months ago. What should you not do? No heavy exercise. You probably shouldn't strain immediately after. No extremes of anything. So diet or temperature or anything like that. Just normal living is what you want to do. So just be normal. Do what you would normally do. There's actually a study in California which showed that people that return to work immediately after their embryo transfer, like same day, had a higher success rate than the ones that went home. So if you're going to go home and you're going to sit there and you're going to go like this and start Googling everything and, oh my God, I felt a twinge and what's going on, you're going to go crazy and you're going to decrease your success because now you're stressed and you're triggering all sorts of negative hormones. If you're at work and you're occupied and you're busy, you might do better because you're occupied and you're busy. So make sure that you're feeling okay. You're not doing anything that's going to stress you out. Some people do better at home. Some people do better at work. Either one will work. So do whatever is best and most comfortable for you. Just no extremes of anything.
Does ovulating late decrease chance of getting pregnant on day 17 of 29 and no surge yet?
Yeah, so we looked at this too. Your cycle length does matter. When you have a longer cycle length, your chances go down. So you want to make sure that your cycle length is reasonably normal. Now, does day 17 of 29 mean much? Probably not. I think most likely day 17, 18, you're still okay. When it starts going past 18 days, you're going to start running into trouble. And those eggs will probably not be as good. And you may start running into problems with the synchronization of your endometrium as well. So we don't love it when it goes that far.
I just found out I'm pregnant. Not me, obviously. Should I start taking aspirin every day since I've had 3 losses?
So good news to everybody out there, including his wife. Tarek, our male web guy, is not pregnant. You heard it here first, folks. So, yeah, should you take aspirin? So aspirin is great for reducing preeclampsia, and it's great for reducing preterm labor. And so I am a fan of aspirin, and we have another fertility factor fiction on that too. I was back from around winter time, I think when COVID struck, maybe a little bit before that. So again, on our YouTube channel. However, you can start bleeding sometimes if you start it once you're already pregnant. So please be cautious. Don't just jump into the aspirin, and make sure it's a baby aspirin. So that's 81 milligrams. But be prepared. There can be complications of bleeding. And it is probably a little bit higher than it is without the aspirin. If you have a well-established pregnancy, they've seen the heartbeat, there's very, very low chance that aspirin is going to screw that up for you. You'd probably still be fine. But you want to definitely make sure that you are cautious and observant, and maybe get an ultrasound if you can, and make sure we're helping you out to make sure that no complications are occurring.
When do you do the first ultrasound for your high-risk patients? Same person asked both questions.
Say that again?
When do you do the first ultrasound for your high-risk patients?
Oh, well, so someone asked a question about infection and being high risk as well. So first ultrasound for us is usually around 6 weeks for our fertility patients. And then if you see a heartbeat, it's a less than 2% chance of miscarriage. If you're really high risk, you've had recurrent losses, we will bring you back more frequently. But for everybody else, the chance that something is going to go wrong is low. If you are really high risk, we bring you back weekly and we check weekly. If you're kind of medium risk, maybe every 2 or 3 weeks. Initially just to help you feel calm and reassured, but you don't really need it. You're probably fine. What does high prolactin do to the endometrium? Just a follow-up to that previous question. It thins out your lining. So high prolactin, can prevent you from ovulating. That's why while you're breastfeeding, you usually don't ovulate and don't get a period. And also it'll thin the lining. It'll prevent it from getting thick enough. I've got an interesting one here. Why do my husband's, and I'll use the correct term, testicles hurt? He's been taking the meds for male speed to increase. No idea, unless you're having way more sex than you were before. But if his testicles hurt, he should be seen, because that can be a sign of a problem, including infection. Testicles are not supposed to hurt, so make sure he gets seen and evaluated. Yeah.
Awesome.
That's all you got?
That's all I got.
Wow. We got 20 minutes to go, team. Anybody has questions, now's the time to ask. Let me see if there's new ones here. Oh, here's one. I know that you've been asked many times, what is the price of IVF and if more than one retrieval is needed? Okay. So we have different packages for different things. So if it's just conventional, sort of you're doing IVF on your own, we actually offer 4 packages. So you can do a natural cycle, and that's relatively inexpensive. We only charge $6,000. You can do a normal IVF cycle, which is $9,995. You can do something called duo-stim if you have weaker ovaries, which is 2 cycles back to back. And we've had a lot of people take that on right now because it's only $16,288. And that's a great opportunity because you're literally getting 2 IVF cycles for the second one for 2/3 of the cost of a full other IVF cycle. And we did that because we feel bad for those patients because they have diminished ovarian reserve. This is their best opportunity, in my opinion, So we're trying to help them out both cost-wise and in terms of therapy. And then for people that qualify and they want it, we have a live birth guarantee. That's a lot more. It's over $23,000, but you're either getting your baby or you're getting your money back. So it depends on which one you want. If you're interested in an egg donor, or you need a surrogate, or you need both, we also have packages for those. I'd have to go through them each and every one, but essentially it's a little bit more expensive. And then, of course, if you're from out of the country, there's just an extra insurance cost and slight increases in some of the costs, but otherwise it's very similar overall.
I actually have some questions.
Okay, let me see if there's any here, or maybe you have some of mine. I don't know. Oh, there's one. Second IUI sperm count, 2 milliliters. 2 million, 20% after wash, 1 million, 60. Oh, okay, so there's 2 million with 20% motility, I guess. After the wash, 1 million, 65% motility. Is the sperm count good for IUI? Should I do another IUI or jump into IVF? I'm 30 years old and have severe PCOS. Okay, so the severe PCOS is not a huge issue. That's always manageable. But the sperm count is really low. So in a study I posted to Instagram recently, it showed that your success rate when your sperm count is 1 million is 5.1% per try for your insemination. So if you're happy with 5.1%, then try. If you're not happy with 5.1%, I would definitely recommend IVF as a better option for you. Oh, we had someone say something really nice over here. That's lovely. We know how busy you are, so we are grateful that you would take the time to prepare and spend an evening with us. Oh, thank you. I love you guys. Thank you for saying that. And if that's who I think it is, that's very, very kind of you to say, so thank you. If you had IUI and 14 days after you take a test and it's negative on day 16, you still didn't get your period, what should you do? Well, if you're still on hormones, you should probably stop them. And if you're not on hormones, I would retest with a blood test if you haven't done a blood test yet, because sometimes the urine tests can be incorrect. And so that's important for you to know. But if you're on progesterone in particular, stop it to see what's happening.
Should we do PIO in the AM or PM?
I don't think it really makes a difference, but PIO, progesterone in oil, needs to be there when you're doing a frozen embryo transfer, in my opinion. And most people are doing their frozen embryo transfer in the daytime. So if you don't start it in the daytime, you won't have the right amount of progesterone in you when you go to do your transfer, unless you're going past 6 days. So I would probably do it in the morning. It makes more sense in the morning. Although your butt will be more sore, but I mean, that's the price you pay.
Is the rate of miscarriage higher in IVF even with euploid embryos?
So not with a euploid embryo. Euploid embryo miscarriage rates, if you're older, are thought to be lower than they are naturally. Traditionally in the IVF program I worked in for years, we actually had a very low miscarriage rate. It was only around 5 to 7%. Normally they'll say that the IVF miscarriage rate is about 20%, but our rate was really quite low. I'm not sure if it was just how vigilant we were or how good the embryology was or what the case was. Maybe all of my prayers. I don't know, but regardless of what it was, we had a relatively low miscarriage rate. But IVF traditionally has fairly similar miscarriage rates to normal miscarriage stats. When you do PGT, that number is supposed to go down. However, remember that PGT for women less than 37 is probably not useful. And so in that age group, there supposedly is some data at the NIH, which I have not seen. I've only heard of as hearsay, but it was from a very reliable source, where they demonstrated that PGT in patients that are younger actually did increase the miscarriage rates, and we do not recommend it for you, so I don't think you should do it. Is the uterine lining thickness measured during a traditional ultrasound? Absolutely, always. Not just the thickness, but the quality. Is it a triple layer? Does it have cysts? Is there a polyp or a fibroid in there? Is there a way we can ask you a question privately? Sure. Go on the Instagram account, rahivictory.md. Send me a DM and I'll happily direct message. I'll happily answer you if I can. Not a problem at all. You got one there?
No, that is officially all the questions at this moment.
There's some here. What other options are there to cause ovulation as I am not ovulating if letrozole has not worked? Oh, okay. So if letrozole hasn't worked for you, you can try higher dose letrozole. So it starts at 2.5, then 5, then 7.5, then 10. Make sure you're taking metformin if you need it. Make sure you're taking inositol and you're taking NAC. And if weight is an issue, you have to deal with the weight with a healthy diet, which is 1,500 calories a day and split into 6 meals, and exercise. There is nothing that is going to work if you are not addressing all of those and you have PCO and you're not ovulating. If you are trying all of those things and you're still not ovulating, you could try a different med, which would be Clomid. And if that's still not working for you, you can try letrozole and Clomid together, or Clomid with DHEA or dexamethasone. There's some different ways to do it. And then the last thing you can try as well is to go into the shots. Now, some people do something called ovarian drilling. You can go in laparoscopically and zap little holes all over the ovary, and it'll work for about 6 months. I'm not a fan. It does a lot of damage to the ovary. It probably overall reduces the function of the ovary, and it's only 6 months and you need surgery for it with all sorts of risks. So I'm not a huge fan of ovarian drilling, but some people really like it. Are there updates on IVF funding? Thank you for working so hard to get it into our area. Yes. So we have a CBC interview about our funding tomorrow morning at 8:10. So that should be awesome. And we also are finding a way to get a bit of an in, which I can't really get into. But we're hoping that the ministry will respond soon, and someone's working diligently on it for us. So we've got all sorts of inroads we're making there. So we're hoping we'll get a positive response soon. We'll see. I've got another one here. Our last IVF with ICSI, we did 3. Well, let's put this up. Oh, no, I can't read it myself. Okay, that's horrible. Our last IVF with ICSI, we did 3 blastocyst transfers with no success. When we saw our RE, all they said was my partner's count was only 2 million and asked us to do a DNA fragmentation test again and said we should go do Pga testing next round. I will be 38 tomorrow. Is Pga testing worth it at 38? Yes, at 38, it's probably worth it to do PGT. So keep in mind at 38, somewhere between 65 to 75% of your embryos are genetically abnormal, regardless of your partner's DNA fragmentation assay. That's just purely based on the woman's egg. So at that point, there is a law of diminishing returns in terms of trying the number of times. And you don't want to keep going through the emotional roller coaster of having to put embryo after embryo inside like you have, and then not get the answer that you want. So over 38, I actually do think it's reasonable to do that, but less than that, we don't recommend it. So if you're less than 38, we don't recommend that you try to do PGT because it's probably detrimental. So they probably did the right thing for you. 3 blastocyst transfers under 38, normally you'd see a pregnancy succeed. So before you do anything and you jump into another IVF cycle, they need to be responsible for you. Dot every I, cross every T. Make sure they figured out why it didn't work the first time. Is it your endometrium? Do you have endometriosis? Were your vitamin levels okay? Is your endometrium a good endometrium? What was your egg quality like? Did they choose the right sperm? If he has high DNA fragmentation, did they use Zymo to reduce that? So there's all sorts of things that are important. Great question. Let me get rid of that one. Oops. How many cycles with Clomid are recommended? 3, 4 sometimes. Sorry, another quick question. Any tips on how to reduce the side effects of metformin? Yes, Number one, if you're taking metformin, start with 1 pill a day. Wait till your stomach gets used to it, then go to 2 pills a day. Wait till your stomach gets used to it, then go to 3 pills a day, or eventually 4. Number two, take it with food. It's a lot easier on your stomach. And number three, don't take metformin, take Glumetza, which is long-acting and has 40% less side effects. So all of those things should work. You got any there?
No.
No? Could you transfer 2 embryos if I like? If it's part of the government funding program and you're doing it at a government-funded center, you have to follow their rules. If it's not part of the government-funded cycle, yeah, of course we can put in 2. We don't necessarily always recommend it, but you can do it. Are all the embryos transferred from the hall to Windsor yet? I am yet to get a notification. Not even close. It is a painfully slow process, and to everyone, I apologize. I have done my utmost to make it go as quickly as possible. It's going as fast as it can be done, or is at least being permitted. Do I take patients in Toronto or only in Windsor? No, we've got loads of patients in Toronto. I had a Toronto practice for 13 years, and I still do. I'm now working at Create. So these days, most stuff is just done online, and then we have everyone investigated, evaluated at Create, and they can help you out for sure. So just get the referral sent to the Windsor office, 519-944-6406. That's our fax number, 519-944-6406. What BMI is the cap before you are not approved to do IVF? 40. So if your BMI is over 40, you can't do it because your risk is too high. Your thing stopped recording. You can't do IVF if your BMI is over 40 because it becomes too high a risk to use conscious sedation on you in the clinic unless they've got an anesthetist there. Also, more importantly, if your BMI is over 40, your success rate is drastically reduced. We have an amazing resource on our website, www.drvictory.com. And if you go to the resource guide, there's something on fertility and obesity. And if you go down to the bottom of it on the left-hand side, it says, open the long booklet. Open the long booklet. It is very important to read that before you pay a penny, or even don't pay a penny. You're doing it funded or insured or whatever. Make sure you check that out before you do IVF. It's actually kind of concerning how high the risks can be depending on which category you're in. So weight can really be detrimental to the process and to you and to your baby. So be very cautious with all that. No, I paid out of my pocket. Yeah, you can transfer 2 embryos if you paid out of pocket, Ash. I'm doing IUI with Clomid. I'm going to do my 4 IUI, all of them with Clomid, but I had Clomid before. I did 3 cycles. TTC naturally, is it okay more than 6 Clomid cycles? So there is a study from 40 years ago or something like that showed that if you did more than 12 cycles of Clomid, your risk of ovarian cancer started to increase. No one else has ever been able to duplicate that, but I also don't think anybody else gives 12 cycles of Clomid anymore. So there's nothing wrong with 6 cycles. And if you want to try naturally after that, like the topic we had tonight, by all means, try naturally. No problems there at all. What dosage of progesterone suppositories do you recommend if taking along with PIO shots? So if you're using Crinone, 1 twice a day. If you're using Prometrium, it's 2-3 times a day. And if you're using Endometrin, it's 1-3 times a day. And that's an easy one. Whoop, I hate when it does that. Does prolonged use of Depo-Over, I think they mean Provera, many years lead to infertility? It won't lead to infertility, but it'll delay your infertility. Depo-Provera can build up in your system and stay there in one study for up to 18 months. So it won't alter your fertility, but it could delay it for sure. What helps to have good egg quality? Have you heard about True Neogen helping with this? This is what an RA recommended, supposedly a secret ingredient, and had a positive result for some of her patients. Never heard of True Neogen. If I had a penny for every time someone said something would work that was a natural substitute, I'd be a very rich guy. A lot of the natural stuff is really not true. So some of it works. Vitamin D works. We know that. Green tea, veggies, the Mediterranean diet, all that stuff works. But does everything that they say work? No, for sure that's not the case. So, to have good egg quality, you want to avoid everything bad: smoking, drinking, drug use, extremes of weight, extremes of temperature, cholesterol, sugar, stuff like that. And you want to replace all that with health. So healthy diet, healthy exercise, low stress, lots of vitamins and things that are antioxidant in nature, and then coenzyme Q10 as well. Benefits help cover the IVF. Some people's benefits help cover IVF. So people with Manulife in Canada sometimes have coverage. Everybody else gets drug coverage. Manulife actually has procedure coverage. So that's about it for that. Winding down, folks. Hi, I'm wondering if IUI is a good option in a woman with very low AMH 0.2 and high FSH. Well, Ro, that's a good question. I'm going to put that one up for everybody to see. Hi from YouTube, Ro. Thanks for joining us there. So yes and no is the short answer. If your AMH is low, it means, unfortunately, and I'm deeply sorry, that your chances are very limited, both in terms of success and time. So on the one hand, spending a fortune on an IVF cycle may not be the most reasonable thing for you to do, because the yield is low, the chances of success are low, and so you got to go into it very realistic about your expectations. On the other hand, it's a much better chance than IUI is to do IVF, and so you really got to decide what's most important to you. You got to know your financial resources. So if having a baby with only your egg and your partner's sperm is the only thing you'll consider, and the money's not an issue, of course you should jump right into IVF. If money is an issue, well, then don't try the IVF. Or if you're willing to consider a donor, I would probably try a couple cycles of IUI. Even 2 or 3 months is not going to make a difference. That study I reviewed showed that it doesn't make a difference even up to 6 months in women with low ovarian reserve. You can find that just last week. I think I posted that on Instagram. So you have time. And so you could try a couple cycles of IUI, and then if it doesn't work, you still have time to try your own or a donor IVF cycle. So you got some time. That's great. Husband asked if walnuts are good to eat for himself. Sure, there's nothing wrong with walnuts. They do have a lot of fat and carbs, so be careful. Okay, 8:59, folks. We got to sign off. I have studies that show long-term use of antioxidants can be detrimental to sperm quality. No, that's not true. There are many, many studies which show that it's perfectly fine. Some show that there's no benefit, but none have ever shown that there's detriment. You got to look at the study that they're talking about. Signing off, guys. Have a great night. Instagram signed off already. Thanks for joining us. We love the guys that are watching on YouTube, so thank you for joining us on YouTube. And we will be back next week, hopefully with another exciting topic. I love this week's topic. Tell your friends, you don't need to jump into fertility therapy if you're not comfortable with it. You do not need to spend thousands of dollars if you're not comfortable with that. You can just try naturally and you still have a pretty decent success rate, even if it's just unexplained. And I say that to every single patient right from the get-go. Your first option is do nothing. Keep trying. So have a great night. Thanks again. Remember, like, comment, subscribe. Appreciate you guys joining us, and we'll see you again on Fertility Fact or Fiction.